welcome today's your international speakers. All the 7 speakers from Dr. Rachel from Singapore, Dr. Yusuke from Japan, Dr. Andy from Indonesia, Dr. Chris from Australia, Dr. Pushpa Raman from Malaysia, Dr. Nasrigul from Pakistan, and Dr. Yoon from Vietnam. So welcome all of you to TNOA and also all our your international panel. So I may not be able to read all in the interest of time. Let's move on. Welcome the Yo International panel. And a warm welcome to our Yo National Faker, the panel, which have been fresh from the elections. They would have been busy with the elections. So I congratulate all the winners and also welcome the Yo National panel, particularly the incoming president, Dr. Devakant and his team. And I'm thankful to your task force of TNOA, particularly the mentors who led this team, gave wonderful advice, Dr. Nivian, Manoj, Vinod, Aarti, and all the other committee members. Thanks a lot for all of your effort. And we also congratulate the OC election winners from TN.
I would like to request Nishan sir to call out the first speaker.
Yeah. It gives me great pleasure to call out Dr. Rachel Chong. So she did her medicine and PhD as a senior consultant in glaucoma service in Singapore National Eye Center and an assistant professor at Duke National University of Singapore, graduate from School of Medicine. Dr. Chong received her BA in Psychology Science from the University of Oxford and her MBBS from University College London. She completed an ophthalmology residency and fellowship training in the glaucoma in the Singapore National Eye Center and obtained her PhD in clinical neuroscience at University of Cambridge. She is currently the clinical lead for myopia glaucoma service at SNEC, and her research focuses on IOP-dependent factors that contribute to blindness from glaucoma. Over to you, Doctor.
Hello, good evening, everyone. Thank you very much. I would just like to share my screen, if that's okay.
Karthik,
Yeah.
yeah, we can introduce the 2 panels also. Aarti, do the honors by introducing the panels. Yeah, and then we'll go for the talk. The 2 panels.
We have with us the VIOs joining across the globe. So it's an honor to introduce Mr. Iqbal. In interest of time, I will request Prasanna that we move on very quickly. So he's country's young glaucoma specialist, and he's going to give us the expert view on this presentation as well. Karthikeyan, can you move to next? We have with us Dr. Sagara, who is consultant ophthalmologist at University Hospital in Sri Lanka. So with this, we'll start the first presentation.
Okay, good evening, everyone. Thank you so much for the kind invitation to speak, Dr. Prasanna, and for the very warm welcome from TNOA. My name is Rachel, and I'm a glaucoma specialist at the Singapore National Eye Center, where I run a dedicated clinical service for patients who are highly myopic, meaning -6 diopters or worse, who also have glaucoma. So as we know, there's a very strong association between high myopia with open-angle glaucoma risk, where the more severe the myopia is, the higher the risk is of open-angle glaucoma. So today I'm just going to share some tips from what I've gleaned from my years of providing service to this very special group of patients, because quite often it's a clinical dilemma in terms of how to distinguish between just a myopic-looking optic nerve and glaucoma in a highly myopic eye. So my first top tip is don't be fooled by the red-green normograms. And the reason for this really is, if you look at these scans from 2 separate patients, the one on the left, who has a hyperope of plus 1.5 diopters, you can see that there's a shift of the superior and inferior peaks on the RNFL thickness plots towards the nasal direction. And the converse pattern is seen in eyes which are very highly myopic. So, for example, this patient who was -9 on the right and -10 on the left where conversely there's a shift of the superior and inferior peaks in a temporal direction. So the result of this really is that the thickness measurements come outside of the normative range. But if you look carefully at the neoretinal rim thickness, as well as the saliency maps on the RNFL thickness maps, actually it's still pretty reasonable in these eyes. So to illustrate this point further, here we have another patient who, just looking at the red-green quadrant maps at the bottom of the report, seems to fall within a normative range. But if you look more closely in the right eye particularly, there's very clear thinning of the neoretinal rim and the presence of a wedge defect superiorly as well. So this corresponds quite nicely with a dense inferior defect on the visual field test. So my second top tip is to remember to look at the macula, and I will explain shortly why. So we know that in patients with glaucoma, even in very early glaucoma, there's the presence of this thing called the temporal raphe sign, where with the advent of macular cube scanning, specifically looking at the GC IPL thickness, we are able to construct contiguous maps of the optic nerve head together with the macula, where, as you can see here, there's the presence of clear inferior losses in both eyes in terms of RNFL thickness. But extending this to the macular region also, there's the presence of this demarcation line in both eyes, which, as you can see here, extends beyond the halfway mark between the inner ellipse and the outer ellipse. And this actually refers to the temporal raphe sign, which actually holds up quite well even in highly myopic eyes. So I also rely on this quite a lot in my clinic. The caveat is that obviously in a patient who is highly myopic, they're also at higher risk of having macular pathology, not just in terms of myopic macular degeneration, but also retromacular traction, presence of macular holes, and epiretinal membranes that can sometimes confound the appearance of the temporal raphe. So this is a different case where, again, you can see here that there's inferior wedge-shaped loss of the retinal nerve fiber layer around the optic disc, although once again, the normograms do not clearly indicate this. When we looked at the visual fields, there was a corresponding paracentral superior defect. And I just wanted to show you another example of macular scanning that I find very useful, which is to perform a vertical raster at the macula. So in this case here, we have a spectralis image going from the inferior to superior region in a left to right direction. And if you look just beyond the fovea in the inferior region, you can see quite clearly once again that there is thinning of the more superficial retinal ganglion cell layers in comparison with the superior region. The RNFL is also slightly thin superiorly actually, but this is definitely a lot more prominent inferiorly. So the other useful thing about doing a vertical raster is that in addition to evaluating the superficial retinal ganglion cell layers, you are at the same time able to exclude the presence of other retinal pathology. Okay. Right. Just to drive home the point again, it's important to look at the macula. So I wanted to discuss this case briefly. He's a 76-year-old gentleman who is a high myope, pseudophakic, and had been seen in the glaucoma clinic, the general glaucoma clinic, for many years. His highest intraocular pressure was 23 in the right eye with thin corneas of about 4 Yeah, and as we look at the neoretinal rim, you can see quite clearly that there's a presence of thinning, particularly in the right eye, as well as a visual field, diffuse visual field defect on that side. So in subsequent years, he was noted to have an increase in his eye pressure on the right, as well as visual field progression and increased cupping, and therefore the surgeon attending to him at the time listed him for a trabeculectomy with mitomycin C. After the surgery, however, he was referred to my clinic when he described that his vision was not very clear. And the referring surgeon wanted a second opinion as to whether or not it was indeed his glaucoma that was progressing. However, at this point, we did a macular scan that showed quite clearly that there was a loss of the ellipsoid zone, as you can see here with the red circles. And I referred him on to our retroretinal colleagues actually for another opinion who did concur that a poor vision in this patient was actually likely due to subfoveal ellipsoid zone disruption rather than it being secondary to glaucoma progression necessarily. So I suggest looking very closely for retinal degeneration in eyes that have high myopia. if the intraocular pressures are well controlled, even if the visual field progresses. I like to do fundal photos periodically for my patients. The reason for this is that it's a very helpful adjunct for determining whether or not there's progression of the macular degeneration. In this case, we had another patient with visual field progression and progressive loss, actually also of central vision. And as you can see here, comparing the fundus photo that was taken several years after the one that was on the left, there was actually advancement of the macular degeneration in the temporal direction, as well as the presence of a disc hemorrhage. Okay, so my last top tip from this clinic is to never ignore headaches. So high myopes are a very special breed of patient, I feel. Quite often they're highly educated. They are, usually present in clinic with a very, very long list of complaints and questions. But it's important to listen out very clearly to what the presenting histories are as well. So in this case, I had a 47-year-old lady who came in with blurring of vision for several months since March 2022. And she originally had seen a different specialist who gave her some lutein supplementation and told her that her blurring of vision was likely to be due to high myopia, although he also informed her that there was no myopic macular degeneration. She had changed her glasses prior to her consultation with that specialist and did not notice any improvement. The other thing she complained of was recurrent headaches that started at the back of her head and that also radiated to her shoulder. And she had these for several years, but it was deemed that it was likely to be related to the fact that she was wearing a headset at work, because she said that when she wasn't at work, she felt a little bit better. Apart from that, there was no other notable medical or surgical history or family history of glaucoma, and she was referred to me as the disc suspect at this point. So she was a very high myope of about -14.5 on the right and -12.25 on the left. Her intraocular pressures were around the sort of low to mid-teens region, and her central corneal thickness measurements were about 520 microns. Anterior segment examination was pretty unremarkable. However, on examination of her optic nerves, it did appear that her cup disc ratio in the left eye was enlarged with the presence of superior rim thinning as well as temporal pallor. So when we looked at the optic disc cube scans, as you can see here, the saliency map clearly shows that in the right eye, the neuroretinal rim is fairly well preserved. There is some artifact blocking the signal superiorly, but the retinal nerve fiber layer thicknesses are pretty healthy on the right eye. In the left eye, however, there was very obvious diffuse loss superiorly, as well as thinning of the neuroretinal rim. And actually, these losses extended even to the temporal area, which suggested involvement of the macular papillal bundle. So this is a region that is a little bit atypical for glaucoma, because glaucoma tends to be more constricted or constrained to the superior temporal and inferior temporal zones around the optic nerve head. So I did a macular cube scan at this point, which showed that the retinal layer thicknesses were very healthy and there was no myopia-related pathology. And this is what the visual field test showed. As you can see here, there's a very dense inferior hemifield defect in the left eye. But in addition to this, actually, there was also the presence of a bitemporal defect respecting the vertical meridian. So in view of this, as well as the fact that she had some temporal disc pallor and a complaint of pain, I arranged an MRI of her anterior visual pathways, which did in fact show the presence of a pituitary macroadenoma, where the mass was compressing and displacing the optic chiasm as well as the optic nerve superiorly on both eyes. So in summary, I think for high myopia-associated glaucoma, it is extremely valuable to look at both macular as well as optic nerve head OCT measures of retinal ganglion cell health. The temporal Raphe sign is very useful for gauging the presence of glaucoma in high myopia. And actually, macular imaging using the vertical raster, I find personally indispensable for also excluding any signs of retinal pathology. It's useful also to have conversations with your vitreoretinal colleagues if there's any uncertainty about whether progressive vision loss is secondary to optic nerve or retinal disease. Repeated imaging and functional testing are often required to establish trends instead of relying on a single time point for diagnosis. This is also particularly because patients with high myopia tend to have a great deal of variability in their visual field performance. Something I do like to do periodically also is using Goldman visual field testing instead of purely relying on Humphrey visual field. And the reason for this is that in patients who have central defects secondary to myopic macular degeneration or choroidal neovascularization, quite often their peripheral visual fields would still be well preserved and intact in an eye that does not have glaucoma. And finally, it's important to also always consider neuro-ophthalmological causes of optic neuropathy as a differential diagnosis in these patients, particularly in the presence of pain and visual field defects that respect the vertical meridian. So thank you very much for your time. I welcome any questions and discussions about these cases. Thank you.
Dr. Iqbal,
Good evening, everyone. I'm grateful to Tamil Nadu Ophthalmic Association for having me here, and special thanks to Dr. Nirmal sir for this wonderful initiative, and my good friend Dr. Prasanna for the invitation. So, as the presenter, Dr. Rachel, she's talk is excellent, and she talked about very elaborately about the myopia and the glaucoma. So, as we already know, by 2050, about half of the world's population will be tends to the myopic, and where almost 10% will be the younger generation, and it is most prominent will be in the East Asian population. So in that case, myopia, as we already know, myopia is a major risk factor contributing to the glaucoma. And if the patient is highly myopic, there are some structural as well as the functional differences, which will be very difficult for us to whether the patient has the glaucoma or not. So in that case, we don't have to solely rely on the functional test or the structural changes, but we have to try to go for both the structural and the functional alteration, whether the optic nerve had or not. And as well as that the peripapillary changes as the macular, as well as the macular changes also affected by the pathological myopia as well. So in that case, it actually depends on how the patient present to you and how the patient is treated for a longer period of time. So whether the patient has the glaucoma or not, it's quite difficult to ask actually, or it's quite difficult to establish. If you don't set the trend, or if you don't see the progression or any changes in the structural abnormality or in the functional abnormality, then it is quite difficult whether the patient is truly myopic or truly patient myopia with glaucoma. So do you have any, I have a special interest in optical coherence tomography angiography. So I try to do OCTA in most of the cases because I have to deal with the younger patient mostly below 16 or even 17 years old. So the normative database is not available for that sort of patient. So in that case, do you have any advice how to assess this sort of patient?
Rachel,
Yeah.
can you stop sharing the screen if it's okay?
Oh, sure.
Yeah.
Sorry, yeah. Okay, so the question was about assessment of 16 to 17-year-olds. Yeah, so that's really interesting. So I work closely with a pediatric glaucoma specialist as well who sees myopes in the clinic sometimes, and she feels that once they're above the age of 13 or 14, actually you can probably apply the adult normative ranges to these patients. Something that she tends to look out for is asymmetry in vertical cupping in both eyes, as well as the presence of neoretinal rim thinning.
Yeah, that's great. Actually, what I do actually, I change the 8 parameters, whether the patient has the 18 years or above, then I go for the normative database, whether there is any changes or not. And another thing is I prefer OCT angio in that cases, because that will give me a much more information than the conventional OCT. So like the peripapillary vessel density or the choroidal vascular dropout, is there any choroidal vascular dropout or not? And in that case, I prefer do it yearly. So if there's any change, or if there is any vessel density changes, or if the patient present with a low vessel density, I assume that it may turn into a glaucoma. So I treated the patient that way. So that's
really interesting. Yeah. I don't personally have a lot of experience of OCT angiography. I know people in Korea do it a lot. The other sort of hesitation I have so I don't have a lot of experience with it, but I do worry a little bit about segmentation. I mean, do you see that the segmentation is good for your OCTA scans, because even with OCT, you know, the segmentation sometimes is a real nightmare to try to interpret.
Yeah, that's true, because the patient is not that much cooperative, and they had to say, and they had to move a lot. So you have to be very careful about the segmentation or the artifact defect.
And also because it's an on-fast evaluation, right? You're kind of looking for on. So if there's any kind of myopic morphological changes to the contour of the optic nerve head, that's probably going to affect the level at which your OCTA, you know, slices are being obtained at.
Yeah,
so
we
I don't have a
to
lot of
be
experience with it, but yeah.
we have to be very careful about that. If you think there's any artifact or something like that, ask the technician to do it again and repeat the test.
Right.
Even a few days after. Yeah.
Great.
Dr. Sagar.
First of all, let me thank Dr. Prasanna Ramesh and the Tamil Nadu Ophthalmic Association for inviting me, as well as the young ophthalmologist from the Asia Pacific region to present here today. And Rachel did an excellent talk on myopia in glaucoma, and Iqbal also gave very nice tips. And I also want to highlight some points. We all know that diagnosing glaucoma in myopia is a challenge. In one side, the risk of myopia is high in glaucoma. The risk of glaucoma is high in myopes, and the other side, most of them are normal tissue glaucomas, and the false positives and rates is high in visual fields and OCT RNFL, ganglion analysis. They all nicely explained by Rachel. And I want to tell a few more tips. And one thing is when we do visual fields, so due to the tilted disc and the macular changes in myopia, they can get unusual false positives, So, and we also get, due to the refractive error, due to the myopia causing peripheral visual distortions. So then with glasses, they get peripheral visual field defects. So one thing I do always is, if the patient uses glasses and contact lenses both, I always ask the patient to wear the contact lenses when they do the visual field. Otherwise, to prevent the visual field defects due to the distortions in the when you use the glasses. And other thing is, we can't rely on one investigation mode, and we have to all consider visual fields, OCT, RNFL, ganglion analysis, everything together. And on the other thing is, we can't just do one assessment and say that there's glaucoma. So we have to regularly follow up the patient closely and see whether there's any progressive changes. Otherwise, the initial, as Rachel described in her first two slides, the two peaks in the retinal nerve fiber layers are more closer in the temporal side. So because of that, so the thicker retinal nerve fiber layer we get in temporally, and more thinner nerve fiber layers in superior and inferior. So that gives a false positive results. So we can falsely diagnose glaucoma in a normal eye in that case. So if we follow the patient closely and do regular investigations, then if there's any progressive change, that will show. So that's the patient, these glaucoma patients, to diagnose glaucoma in myopics. So we need this multimodal investigations as well as the close monitoring and follow-up. Thank you.
Thank you for the wonderful discussion.